Okay, so this topic is one that I have been really enjoying for the past 10 years. We put a dual source scanner in our ER 10 years ago and started getting into dual energy CT. And it's been a lot of fun over that time to really learn how it works and to figure out where it adds clinical value for us in the ED across a wide variety of body regions. These are my disclosures. These ones are relevant to this talk because I have had an institutional research grant from Siemens on these topics. And Siemens also has provided speaker honoraria for some talks that I have given for them in the past on this topic. So the outline of this talk is to help everybody understand some of the fundamental principles of dual energy CT image acquisition and material differentiation, to describe some common dual energy post-processing techniques, and to then demonstrate clinical scenarios in which dual energy adds value for us. So let's start with some fundamental principles. Here on the left, I'm showing you an 80 kVp scan. Here on the right, a 140 kVp scan. And you're going to see a lot of these sorts of charts in my talk, where on the y-axis we have Hounsfield units at low kV, and on the x-axis Hounsfield units at high kV. We recall, of course, that water and air are calibrated to be at 0 or minus 1,000 Hounsfield units at any kV, and that most soft tissues in the body, like blood or muscle or whatever, tend to fall very close to this identity line with very similar Hounsfield unit values at low and high kV. But we also know that we have certain materials that fall off this identity line, so that iodine in the kidney here shows us much higher Hounsfield unit values than we see at 140 kV. Calcium similarly has a slope above this identity line, though it's less than that of iodine. And then we have certain other materials that fall below the identity line. So fat, which contains a lot of low atomic number stuff, is darker, lower Hounsfield unit values at low kV than it is at high kV. And similarly, uric acid is another material we love with dual energy because it also falls below the identity line here. So if we think about what we actually need for dual energy CT, there are a couple things. The materials have to have distinct X-ray absorption characteristics at each spectrum, which means that they need inherently different X-ray absorption behavior, largely driven by atomic number and K-edge physics. But we also need different enough spectra in our acquisition to make those inherent differences visible. And this is called spectral separation. So as one example, if we tried to put 139 Hounsfield units here and 140 Hounsfield units here, it doesn't matter what the material's behavior is, they're going to look to be at identical Hounsfield units. So we need that spectral separation in our acquisition technique. I want to spend a moment to make sure everybody understands the differences between KeV and KVP, because there's often confusion about this. So KeV is X-ray energy. KVP is the kilovoltage we apply in our X-ray tube between the cathode and the anode. So you'll recall we have a vacuum, cathode, anode. We heat up the cathode, liberate some electrons, and we accelerate those electrons across the kilovoltage potential, let's say 140 kV. The X-rays acquire 140 keV of kinetic energy, and then they slam into the anode and liberate that energy either in the form of X-ray or heat. So we end up with this spectrum, in this case the blue spectrum, where the maximum X-ray energy we can produce is 140 keV, but we have this whole spectrum below. If we take two of these spectra, 100 and 140, and we normalize to the same area under the curve, which is to the same X-ray flux, we can see that we have a lot of overlap between these two spectra. This is not very good spectral separation. There's some. The mean energy of these spectra is a little bit different, but it's not great. So what do we often do in dual energy? We go to wider pairs, 80 kV, 140 kV. The problem is that 80 kV makes it hard to penetrate through large patients or dense body regions. And so that's one approach that is often used. Another approach on the dual source scanners that can be used is, since we have two X-ray tubes, we can put a tin filter in front of this blue spectrum and attenuate the lower energy components so that we harden that spectrum and make a better spectral separation between the 140 with tin and the 100, allowing us to better penetrate through our larger patients. All the manufacturers have very different approaches to dual energy acquisition. This is the GE and more recently the Canon approach, which is rapid KV switching. So about 1,000 times every gantry rotation, we switch between 80-140, 80-140 every other projection. And so we have these interleaved projection data for high and low KV that we can use as the basis for a dual energy post-processing. Siemens uses the dual source approach that I mentioned, where we have basically two scanners crammed into one gantry. We have one tube operating at either 80 or 100 kV with its detector. We have the other tube operating at 140 or 150 kV with the SN or tin filter in front of it with its separate detector array. So now we have two simultaneously acquired data sets at high and low kV that we can use for our dual energy post-processing. This is the Philips scanner approach, where they have a single tube and operating always at a fixed kV, but they have a dual layer detector where this central green detector preferentially absorbs the lower energy X-rays, leaving more of the higher energy X-rays to be absorbed in the orange outer layer. So we have spectral separation now at the detector layer. And conceptually, this is kind of more similar to what's happening in photon counting CT as well, where the energy differentiation of those X-rays is occurring at the detector itself, which I don't really have time to get into in more detail today. One of the common misconceptions is dual energy CT must be double dose CT because we have two sets of data that are acquired. But in reality, what all of the manufacturers have done is essentially split the dose of a conventional scan roughly half and half between the high and the low energy acquired data. And so you can see here from the roughly first 9,000 scans that we did in 2013, this is what we saw for CTDI distributions. The red line is the 25 milligray diagnostic reference level that's used for regulatory purposes. And we were able to do very respectable low dose scanning for all but our very large patients on this scanner. Let's move on to some of the post-processing techniques. Two material decomposition is an algorithm in which everything in the image is assumed to be composed of only two materials. We have to pick material basis pairs that have fundamentally different X-ray absorption behavior. So common pairs that are used are photoelectric versus Compton scatter, or iodine versus water, which is essentially the same basis pair almost. Each voxel in the image is then decomposed into the contributions from those two basis materials that would account for the observed X-ray attenuation with the high and the low energy acquisition. The caveat here is that if you have materials other than the two in the basis pair, it's going to show up in both sets of images. So calcium is the classic example. Calcium appears in both iodine images and water images, and other materials like calcium or anything else can be generated by linear combinations of those basis pair images. Here's an example lent to me from Dr. Marin at Duke on a GE scanner showing an iodine no water image and a water no iodine image. And so you can see, if you look at the aorta and the kidneys, most of this contrast has been subtracted away on this water no iodine image. Virtual monochromatic imaging is an extension of this concept where image content at simulated KEV values can be generated based on the measured attenuation at low and high KV by appropriate linear combination of those basis material pairs. So if I take this coronal image through this kidney with this lesion hanging off the lower pole, I can plot regions of interest here as a function of simulated KEV level. We can see that the iodine-laden renal parenchyma shows this characteristic increase in attenuation at lower simulated KEV level. The fat outside the kidney goes to the lower Hounsfield unit values at low KEV. And this lesion here shows very flat behavior, indicating that there's no iodine within This is a non-enhancing lesion, a benign hyperattenuating cyst. We can do these sorts of measurements, but we can also create images at these desired KEV levels. And you can see here that the high KEV image essentially eliminates all of the contrast. This is sort of a quick and easy way to do something like a virtual non-contrast scan. And on the flip side, if we go to low KEV, we accentuate all of the iodine content. And this is a tool that many people like to use to salvage a poor quality CT angiogram or to better visualize differences in contrast between lesions or parenchyma. 3-material decomposition is really the mainstay that we use on our scanners. Here's how it looks. Hounsfield units at low kV, Hounsfield units at high kV. We have a base material line defined by the typical attenuation, in this case of fat and the organ of interest at each kV. And as we add iodine, more and more iodine on top of any of these areas, we march up these sloped lines like I showed you earlier, so that everything in the blue shaded area here is attributed to iodine in this decomposition. So if we take that same image and we take a voxel, we can now decompose it into its iodine content, and what's left at the base material line is the virtual non-contrast attenuation. So we can turn this conventional image into a virtual non-contrast image with the iodine removed. We can look only at the iodine content itself and color code that, in this case, in orange. Or what we do as our mainstay in all of our scans is we superimpose this color-coded iodine content on top of the grayscale virtual non-contrast image to create this iodine overlay image, which is what we send to PACS. And here you can nicely see that there's no orange in that lesion. There's no iodine. We can very quickly see that this is a non-enhancing lesion and dismiss it as benign. So now that we've sort of gotten the technique out of the way, let's talk about how dual energy can help us better take care of our patients. And I'm going to step through some of these broad categories here with a lot of case examples. Detection. Dual energy makes it possible for us to identify pathology that is otherwise invisible or challenging to detect on conventional CT. Here's an example. This is a coronal image of the head. On all of our CT scans, we do a calcium-based bone subtraction reconstruction to eliminate the skull and to better show us a very subtle subdural hematoma that's otherwise hiding under the brightness of the calvarium here. We do this on every head CT in the axial and the coronal plane. Here is a patient who clearly has a large mass in the central abdomen. What's a little harder to see until we turn color code the iodine is this hypervascular metastasis in the liver. It's visible here, but it's more visible here because we're accentuating the iodine content with this color overlay. This is a patient with a normal looking gallstone on CT. However, this gallbladder contains multiple gallstones within it, as we can see on this MRI. And if we adjust the KEV levels, we can see that we can make these stones much more visibly dark at low KEV and bright at high KEV. This is because these non-calcified stones have a lot of cholesterol content, which behaves very much like the fat I showed you earlier. And if we plot contrast between the stones and the bile, we can see that we're unfortunately right around zero at the typical energy levels, 70 keV, that are most similar to a typical 120 kVp scan. But we can make this contrast fall away from zero at low KEV or at high KEV. Pyelonephritis is a nice use for this technology. Here, if you're paying attention, you can see a little bit of subtle urothelial enhancement in the renal pelvis here. Does this patient have changes of pyelonephritis? Hard to tell until we turn on the iodine overlay images, and we can much more easily see the differential enhancement throughout this right kidney, indicating that we have not just pyelitis, but pyelonephritis. This is a patient in the ED with abdominal pain. The bowel looks morphologically quite normal here. There's no distension or wall thickening. If we look at our iodine overlay images, though, look at the distribution of iodine within the bowel. You can see there's no iodine within a lot of the small bowel and the right colon. If we look at this on static images, here's the normally enhancing jejunal wall. Here is the non-enhancing ileum as well as the right colon. And if we look carefully, here's a fairly distal SMA thrombus causing this without any secondary signs of bowel ischemia on conventional imaging. So we love this technique for bowel viability, and our surgeons love it too. Splenic laceration, this is not our best trauma scan. It's a little bit embarrassing, the image quality actually, but we can see something's going on with this spleen. We have probably a subcapsular hematoma. Hard to tell what's going on in the parenchyma. We can dial down to low KEV, really accentuate differences in iodine content between portions of the parenchyma, highlighting this laceration through the splenic parenchyma here. Subtle fractures. If you're paying attention, you can see these very subtle fracture lines here. We know there's a fracture because we have lipohemarthrosis right here, but it's hard to see the fracture itself. What this is the bone marrow application. This is a virtual non-calcium application that subtracts away the attenuation from the trabecular running through the marrow space. What's left over is the attenuation of the marrow itself, which we now color code, where green is high attenuation, purple is low fatty attenuation. And so anything that increases marrow attenuation, edema, hemorrhage, metastases, show up as green on the baseline of the fatty marrow. Let's move on to characterization. Dual energy can provide additional information about material composition beyond traditional attenuation values, making it possible for us to further characterize findings without additional imaging. Here's a patient that had had a stroke and had a left M1 segment thrombectomy, and on the post-procedure scan, we see these bright foci in the brain. We do our iodine overlay images and matching virtual non-contrast images. We see that each of these areas are color-coded orange as iodine and disappear on the virtual non-contrast image. This is definitively iodine content, contrast staining post-procedure, not post-procedural hemorrhage. No way to tell that from a conventional scan alone. Here's another patient after intervention with this bright spot here. This does not color code orange. It persists on the virtual non-contrast image. This is hemorrhage, not iodine staining. This example is a mixed case where the central portion does not color code orange. It persists on the virtual non-contrast. That's hemorrhage. The outer rim is orange and disappears. That's a rim of contrast staining around a central area of hemorrhage. Very hard, not hard, impossible to tell that apart on the conventional imaging. We also like this technique for CT venography. We can clearly see that there's something abnormal going on here in the region of the transverse sinus. If we turn on our color iodine overlay, we can see nice enhancement in the right transverse sinus. The left is thrombosed, but the adjacent cortical veins show some enhancement here. Hard to tell those apart on the conventional scan. Iodine versus calcium is an interesting problem, as I mentioned before. Here's a patient scanned for other reasons who has had an endovascular stent. We see some bright stuff outside the stent. And the question is always, is this an endo leak or is this calcification? This spot here color codes and disappears. That is iodine. That is an endo leak. This stuff here along the wall, it color codes on the overlay and persists on the virtual non-contrast. This means it's not iodine. And as you'll recall from earlier, calcium persists on both the virtual non-contrast and the iodine map in three material decomposition. And just look at the spine. There's some orange here. It's also on the virtual non-contrast. So why does this happen? As I mentioned to you, our three material decomposition algorithm is designed to differentiate iodine from other. Calcium falls along this curve here. So if we have increased attenuation from calcium, this algorithm does exactly what we've designed it to do, and it decomposes that into how much iodine and how much virtual non-contrast attenuation would be needed to account for the observed attenuation. And so calcium ends up being split roughly half and half between the iodine overlay images and the virtual non-contrast image. This means that we do need matching virtual non-contrast images along with our iodine overlay images to be able to tease these things apart. Here's an example of a patient with trauma, liver laceration. There's some higher attenuation within the central portion. We can clearly see that this is bland thrombus, not active extravasation, because of the iodine dual energy content. Here's a patient who comes in with GI bleeding, who has some bright spots in the stomach here. If we look at these, this one, orange, disappears. That is active contrast extravasation of iodine. This other one does not color code as iodine and persists on the virtual non-contrast. This is Pepto-Bismol that the patient took for their abdominal discomfort. We can tell them apart with dual energy, not on conventional imaging. Another characterization tool we use is differentiating renal stones. What we typically do here is there's this separation line, and above this we have color-coded blue calcium-based stones. Things that fall below the separation line are color-coded red, and we can characterize them as uric acid stones. So we can do a chemical composition characterization of the stone when we first detect them, which matters because these uric acid stones can actually be treated with alkalinization of the urine by certain medications. Here's a patient who came into the ED with a swollen, red, and hot great toe. And we see on the x-ray, we have some erosions with sclerotic margins, not just here, but we also have one here in the anterior calcaneus. This is suspicious for gout, even though the clinical concern was for a septic joint in the toe. So we did a gout scan, and this scan uses that characteristic behavior of uric acid to color code uric acid deposits as green. And we can see the gouty tophi in the great toe, in the calcaneus. We can also see additional areas of uric acid deposition in the tendons of the foot that are not visible by X-ray. And this has proven to be a really nice way to do non-invasive diagnosis of uric acid content with the potential to monitor treatment response from gout after medication. And we've built a very robust gout program at our hospital that the rheumatologists love because they no longer have to stick needles into these painful joints. Ease of interpretation. Dual energy can make imaging easier for us to interpret, either reducing our interpretation time or improving our diagnostic confidence. CT angiography of the head and neck. I personally hate MIPS through the neck because we can never see the vertebral arteries. They're obscured by the surrounding bone. But if we do a calcium-based bone subtraction technique, we can null the attenuation from the bone, and we can create MIP images that look much more like MRI than by CT, except for some small areas of streak artifact from dental fillings. Here's another example of a patient with a small aneurysm in the cavernous carotid, very challenging with the bone there, much easier to see after the bone's removed, and volume rendered images here look very similar to what we can create with a conventional digital subtraction angiogram. This is a patient, this was lent to me from UT Southwestern. This is on the Philips scanner, conventional images, 45 keV images. The first thing to look at is the attenuation of the vessels. We've created a beautiful CTA from a not so great CTA by dialing down to 45 keV. The other thing you can see is that the gray-white differentiation is accentuated at low keV. And if we plot that differentiation, it just goes higher and higher the lower we go with our keV setting. Renal mass assessment. I personally hate reading renal polycystic kidney disease studies because you're always trying to match non-contrast to post-contrast images and measure Hounsfield units in both cases. Here, we have two lesions that are clearly not simple cysts. This one contains no iodine content, benign hemorrhagic proteinaceous cyst. This one contains heterogeneous enhancement. This is a renal cell carcinoma. And the beauty of this approach is that the dual energy or the iodine information is inherently perfectly co-registered with the non-contrast data. There's no measuring, trying to match Hounsfield unit measurement locations on different multi-phase scans. We found that this allowed us to reduce our interpretation time for the kidneys, but far more exciting than that was the increase in diagnostic confidence we saw, where these bars show how many of our radiologists felt confident that enhancement was absolutely present or certainly absent on these scans. And so we saw an increase in diagnostic confidence because of this co-registration. Can also be helpful in other areas. Here in the pelvis. We see something's going on down here. It's hard to tell exactly what. If we show the iodine content distribution, we can see nice preserved enhancement in this ovarian parenchyma surrounded by non-enhancing material hemorrhage. This is likely a hemorrhagic cyst causing hemorrhage to surround the ovary, but we have preserved enhancement here. And I would argue that ultrasound is not needed in this case. We know that there's enhancement here. The only thing ultrasound's really going to add is whether there's Doppler flow, but that's exactly analogous to what we're seeing with this iodine content. Let's move on to prognostication. There are areas in which dual energy can provide prognostic information for us, particularly related to the iodine content within affected tissues. Here's a patient with a large intracranial hemorrhage. We have a multi-phase scan, and we can see, if we're paying close attention, that we have a spot sign with the appearance of contrast on the arterial phase that grows and distributes on the venous phase. But we can also diagnose this very easily with a simple iodine overlay image, highlighting that area in orange, and the fact that it disappears on the virtual non-contrast image. I will always jump to the iodine overlay image for anything relating to iodine extravasation, and can certainly go back to confirm on the additional source images, but I find this a much faster way to do these scans. And in this case, the spot sign is a very important prognostic sign for hematoma expansion. The other area where you'll see this often is for PE-CT. Finding these PEs is not much of a diagnostic challenge, but what is helpful here is to see how much of the lung is not enhancing as a result. And there have been some studies showing that the quantity of non-perfused lung is a good prognostic indicator for which of these patients might need more aggressive treatment. Pancreatitis is another use case, 2 different patients here with pancreatitis. This one on our left shows preserved uniform enhancement throughout the parenchyma. This one on the right shows this large gap in enhancement within the pancreatic neck in this necrotizing pancreatitis. Much harder to tell for sure on the conventional images. Small bowel obstruction, we love this application. Here's a short segment of bowel in a closed loop obstruction. We can see that there is no enhancement within that loop compared to the enhancement within adjacent loops. This bowel loop is not enhancing and is either dead or dying. This patient needs to go rapidly to the OR. And again, this is one of the applications that the surgeons often come to us and say, hey, can you show us that funny orange thing that you guys do? Because we want to understand whether this bowel is viable or not. Dual energy can provide additional robustness for us in the ED in our routine imaging by enabling more complete characterization of unexpected findings without need for multi-phase or subsequent imaging. One of the fun things in the ED is that we never know what we're going to find on any of these scans ahead of time. And here's an example of a patient who just came in with abdominal pain, had previously had a pseudoaneurysm embolized, and now has this large hematoma here. And as we can see, we have this unsuspected area of iodine content, disappears on the virtual non-contrast. This was a rebleed from that same area that had previously been embolized. Here's another example. We not infrequently see these bright spots in the bowel lumen, and I hate having to think too hard about whether this patient has an unsuspected GI bleed or whether this is ingested material. We can answer that with dual energy. We don't have color-coded iodine content. This persists on the virtual non-contrast. This is something that the patient ate, whether it's Pepto-Bismol or pill fragments or something else. There are certain scenarios in which dual energy can reduce the need for us to keep patients in the ED for follow-up imaging. And the best use case here that we found is to differentiate intracranial calcification from potential hemorrhage. So here's an example of a patient who comes in after a trauma. There's this small bright spot in the right frontal lobe, and we don't know whether this is pre-existing calcification or whether this is a small area of hemorrhage related to their trauma. So we keep the patient in the ED for 6 hours and we do another scan and it looks exactly the same. And we still don't know whether this is calcium or hemorrhage. We do know that it hasn't changed in 6 hours, so we're fairly reassured that it's not an expanding hematoma and that the patient can go home. But what we now do for all of our non-contrast head CTs is we use this algorithm to do not now an iodine overlay, but a calcium overlay image. So now we are color coding calcium as orange, and this disappears on the virtual non-calcium image, definitively characterizing this as calcification. There is no need for the follow-up CT scan or to wait those additional 6 hours in the ED. How does this work? Well, we took our usual 3 material decomposition algorithm and simply changed the parameters from the slope of iodine to the slope of calcium. And I should mention this is not yet FDA approved, but we use it anyway. So it's a simple tweak to the algorithm. Here's another example, patient who has calcium within the choroid plexus that disappears on the virtual non-calcium image, hemorrhage in both occipital horns that persists on the virtual non-calcium image and does not color code on the calcium overlay image. Here's another patient with multiple METs that shows some rim calcification that is distinct from this area of hemorrhage that does not behave like calcium. And finally, here's a glioblastoma crossing midline in the corpus callosum. We see calcium content in this portion on the right, hemorrhage in this portion, this portion on the patient's left, hemorrhage in this portion on the patient's right. We found that this improved our diagnostic accuracy, surprisingly to perfection, with a number of very challenging indeterminate foci in a reader study that we did. But more exciting than that to me is the increase in diagnostic certainty, because if I say I think it's probably calcium and I've technically gotten the diagnosis correct, unless I'm confident about that, the patient's getting their follow-up scan and increased length of stay. So what you can see here is that for both readers in this study, we were able to trade up in diagnostic certainty, eliminating all uncertain, completely uncertain cases, and trading up a lot of the likely to definite calcium versus hemorrhage. Moving on, radiation dose reduction. Dual energy can be used to eliminate those additional scan phases in traditionally multi-phase exams, and it can also eliminate the radiation exposure of additional scans that would otherwise be needed for follow-up characterization. So here's a classic example, GI bleeding. Traditionally, people do a non-contrast phase, an arterial and a venous. Right off the bat, we get rid of the non-contrast. We do a virtual non-contrast from this delayed venous phase. We can nicely see that this diverticular hemorrhage that is apparent on the arterial phase and growing on the venous phase, that iodine disappears on the virtual non-contrast. We know definitively that this is iodine. We don't need a true non-contrast scan and can save a third of the radiation dose of this multi-phase protocol. We can also reduce the need for follow-up imaging when we definitively characterize pathology at the time of initial detection. And so here's an example of a patient with a trauma who has a greater trochanter fracture here in the hip. This patient got an MRI showing that, in fact, this is an intertrochanteric pattern of bone marrow edema. Had we been routinely using our dual energy data for the bone marrow application, we could see this matching area of bone marrow edema, and I would argue absolutely no need to do that follow-up MRI. The other area that we use a lot with dual energy is characterization of incidental lesions, particularly incidental renal lesions. We found that about 5% of all the patients who get scanned with abdominal CT in the ED have indeterminate renal lesions that are higher density than simple fluid. We found that we could exonerate about half of those as benign based on their absence of iodine content on dual energy, which means if you multiply this number by this number, you get about 2.7% of all of our patients that get abdominal CT, where we can avert downstream workup with additional CT or MRI. To do this, we have to perform dual energy routinely, which we do on all belly CTs. And if we do that, we can really reduce patient anxiety, resource allocation, cost, and radiation exposure. So the bottom line here is if we see one of these lesions, we have no iodine on our overlay images, we do not recommend follow-up. So I'm going to stop there. I hope we have some time for questions. I haven't really been keeping track of how much we have, but I'd love to take any questions that any of you have. I see.
Sodickson.
A pleasure.
That was amazing, and I loved the picture. The pictures were so awesome and so helpful to really see the effects.
Nice, thank you for that. Yeah, it's been a fun area, and often what converts people is seeing these pictures, and so workflow is often a topic that people talk about here, and the key thing is to get these images in front of people in PACS. And so, it only takes a few cases where people say, oh, this is really helpful information to convert people at our institution.
Mm-hmm. I have a question personally. I'm a total lay person, no clinical background. My question would be, after being converted by your talk, what's the downside of using dual energy? Like, is there anything it can't do?
Yeah, the downside is really just that there's a learning curve for adoption, and you have to sort out your workflow for creating these additional images, and you need your radiologist to understand what they're looking at so that they can interpret it properly. And so, unfortunately, as was mentioned, I think in the morning session, that we had, adoption has been disappointingly slow. I think in part because people are used to reading their grayscale CT scans, and something new like this requires some change in mentality and getting used to it. But for those who are willing to put in the time, I think people find it tremendously helpful and valuable and interesting. I do have a question from Jan. Or Jan, I'm not sure how to pronounce properly, but the question is, what's been your experience using dual energy to reduce metal artifacts? Are you finding it superior to MARS? MAR or IMAR has been an issue for us with iterative reconstruction. Our rads don't like it, wondering if you're getting more success mitigating metal artifacts with dual energy. My answer is that IMAR and the other MAR algorithms, well, let me back up. The way those work, those metal artifact reduction tools work, is they basically try to find photon-starved projections next to a hip prosthesis and to sort of interpolate the projection data with adjacent projections that are not photon-starved. And so it does a great job, in my opinion, of getting rid of streak artifact, but it does introduce some additional artifact and kind of fuzzy distortion around the areas of metal. That said, I think those projection-based metal artifact techniques like IMAR are far better than what you can get with dual energy. People have talked about using high KEV virtual monochromatic images to reduce metal artifact. And it's highly variable how well that works depending on how much metal there is and what the configuration of the metal is. So my personal feeling is that I've found a lot more success with IMAR over high KEV dual energy images. There was another question in the chat. I see the number of images in PACS and network speed can be an issue with dual energy CT, but can be done. And Loretta, I agree with that. We need to be conscious of how much we're sending in PACS, not just because of PACS and network limitations, but also because of concerns of overwhelming our radiologists. We all have thousands of images with each of these CT scans, and how much more are we going to add? And so I think, in our process, it's really been about finding, what are the applications where we find this most helpful. And in the abdomen, for example, iodine overlay image and virtual non-contrast image That's all that we send. We do send it in both the axial and the coronal plane, but we don't do all this other stuff. The other thing to realize that I've tried to train our radiologists is that they don't actually need to review all of the dual energy images. Those are there for problem solving, for troubleshooting. I'm happy to serve as an expert witness if anybody gets sued because they didn't see something on one of the extra dual energy images that were there. But think about it. We send thin images all the time to PACS for problem solving or to make MPRs if we need to tease something apart. None of us routinely look at every thin 0.6 millimeter image throughout the entire body. So we have some precedent for additional series that are there for problem solving. But yes, we do have to be conscious of how long it takes to create those images. We need an efficient workflow to do that automatically that doesn't add burden to our technologists or our radiologists. And we need to make sure that our PACS IT folks don't get unhappy with us for the extra burden that we're placing on the systems.